general surgeon with distinguished expertise in robotic, metabolic, and bariatric surgery, abdominal body reconstruction, and reflux procedures, and interventional bariatric endoscopy. He currently serves as the medical director of bariatric surgical services and director of the robotic surgery program of Massachusetts Medical Center. And he holds academic positions as clinical professor at the University of Houston and the Sam Houston State University College of Osteopathic Medicine. But beyond and above his clinical and academic roles, Professor Oviedo is a global leader in robotic surgery, and this is the main reason for which we have him with us today. He is the CEO of the Robotic Global Surgical Society, or better known as TROGGS, deputy editor of the Journal of Robotic Surgery, and associate editor of Obesity Surgery. With his exceptional background and in robotic bariatric surgery, surgical education, and surgical innovation, Professor Oviedo brings a uniquely forward-thinking perspective to BariClub tonight, which is the gist of it. Professor Oviedo, the floor is yours. We are ready for you to rock it.
Thank you, Professor Pantelis. Thanks very much, everyone. Can everybody hear me? And can anyone see my screen?
Yeah, it looks perfect and you sound good. Thank you.
Okay, thank you. Thank you so much. Well, it's really my honor and pleasure to say hello to all of you in beautiful Greece and to the world. I'm a big fan of the work that Professor Pantelis has been doing at BariClub. I've been following you. And on behalf of the Robotic Global Surgical Society, TROGGS, which I proudly serve as CEO, I want to say hello. I want to welcome you to join TROGGS as well if you're interested. I hope so. And I look forward to a productive discussion. Less than 30 minutes, I hope to illustrate to you how passionate I am about robotic, metabolic, and bariatric surgery. Not only as an educator, not only as a scientist, as a researcher, but also as a surgeon who practices daily metabolic and bariatric surgery, among other technologies and techniques. I'm very passionate about this, and I want to share this passion with all of you. And without any further ado, I'd like to say that I have no financial disclosures. I especially want to acknowledge Professor Pantelis for the kind invitation. It really is a privilege for me. It's truly an honor, and you should be very proud of the work that you're doing. It's really special to me to be here with you. Greetings from Texas, USA, where I'm in my office, in the comfort of my office. It's noontime. I want to also thank the Nano Banana from Google Gemini AI, because actually this morning I had already finished my presentation and I asked Nano Banana, Google Gemini, hey, can you please make an illustration of robotic bariatric surgery? Just having fun. And look at the illustration that the Nano Banana gave me. It's actually not that bad. You can see the concept is, as you can see, this is a bariatric, robotic metabolic bariatric surgeon working with an open console. So I'm assuming that the surgeon may have some special lens so that the camera tracks the retina movements. These are some controls, and you can see a beautiful monitor there with a lot of metrics and parameters, and I'm sure that there is navigation technology there. There's AI. Undoubtedly, there's going to be AI incorporated. And look at this. The only thing I see is this patient does not seem to have severe obesity, but who knows, right? Maybe it's a revisional operation. You can see 1, 2, 3, maybe 3 arms. You can see a lot of people watching. And it's really not a bad illustration. And the Gemini even thanked me for using it. And I gave it a thumbs up. So this is an example of what you can do. This is an example of the OR of the future, which is becoming the present. This is actually coming to us. And I'll tell you something. I learned this a long time ago. We're not going to be replaced by AI right now, not in our lifetime. It's not going to happen. We still have to do trauma. We still have to do emergency surgery. Even if every hospital in the world had a robotic platform, you're not going to get the technologists and the nurses and everybody else to help you all the time. The robot may be used by someone else. There's always going to be accessibility issues. So you're always going to have to do laparoscopy and sometimes open surgery, and that's okay. We train our trainees to do everything, to learn to do everything. Endoscopy, advanced endoscopy, bariatric endoscopy, laparoscopy, robotics, intraluminal surgery, everything with AI. So we're not going to be replaced by AI anytime soon, but we could be replaced by surgeons who embrace and understand AI and at least are willing to try it out for the benefit of their patients, whether preoperatively with algorithms and discussions, or tumor board, or in metabolic and bariatric surgery, multidisciplinary decision making, or intraoperatively navigation, feedback, error, prevention of errors. We can talk about that in another on another series, another webinar. But let's focus on metabolic and bariatrics. Professor Pantelis asked me a question, and he said, Rodolfo, I challenge you to show the audience why it would make sense to learn and embrace robotic bariatric surgery. And I said, dear friend Athanasius, I accept the challenge. So let's do this. Today, I want to show you the elephant in the room. What is the most uncomfortable question that we need to ask ourselves today? And I realized that I'm in the presence of wonderful, incredibly talented surgeons from Greece and from around the world. And I want you to know, if you are a metabolic bariatric surgeon who already embraces robotics, wonderful, that's great. And I welcome your comments and suggestions at the end, and we can have a productive discussion. Now, if you're not, and you are an incredible metabolic bariatric surgeon, but you just don't know how to embrace robotics yet, or you have access issues, maybe you're not really sold on the idea, and that's okay, we respect all points of view. Or maybe you're interested, but you haven't had the blessing, the privilege, the chance to train yet. We have solutions for you, and let's talk about it at the end and throughout the talk. So what is the elephant in the room here? What's the uncomfortable question? The question is, you see behind me, you can see those instruments that are articulating instruments. Excellent instruments that articulate very well. Recently at TROGGS on Surgeon, our webinar platform, we had an amazing webinar with our medical students and student doctors from the United States and from the Intercontinental Training Program from TROGGS, where they hosted an amazing lab where we were displaying these instruments that bend and articulate like the human hand. If you were to watch them on a monitor, you would swear you're looking at robotic instruments. There's no way for you to know that these are not robotic instruments. But guess what? The company is already working on developing its own robotic platform. It's coming, and it's going to be called Stark. So this is just an example of multiple companies that are reverse engineering the system, and they started with the articulation, and now they're going all the way to robotics. And it's brilliant. It's brilliant what they're doing. And now, by the way, I'm not a consultant for them. I'm not on the payroll, nothing like that. I'm just saying I admire what they've done. But with instruments like this, you may argue, is robotic bariatric surgery really justified? Is it needed? Or can I just do surgery with straight stick laparoscopy? Or can I do it with these fancy instruments? Can I do that instead of using a robot? $1 million machine, 2 million, 3 million, whatever it costs? And the answer is yes, it's justified. I hope to convince you. So my objectives are very simple: to discuss my personal experience with robotic metabolic bariatric surgery, both from the urban inner city to the rural community hospital arena, to academic centers, to global surgical education. And I have had experience in all of these realms. I'm humbled to say I do have experience with all of them. And there is a common element in all of them. You can still do cost-effective, highly efficient robotic metabolic bariatric surgery if you train yourself, if you train your team, if everybody puts effort into it. It's absolutely possible. You can do it in any environment, whether you're in the big city in beautiful Athens, or whether you're in a rural community center in other areas in the provinces of Greece, or anywhere in the world for that matter. To present relevant evidence from the literature and my own literature on robotic metabolic bariatric surgery, both from my own perspective, retrospective studies, systematic reviews, meta-analysis on behalf of TROGGS, all the way to ASNDS Clinical Issues Committee guidelines, where I serve as well very proudly. And to illustrate the technical advantages, why not? I'm going to show you a video where I show you my preferred technique for robotic hands-on anastomosis and ICG fluorescence. So everything started with this publication back in 2016, reflecting 4 years of trajectory, 3 years of trajectory of my experience in a community hospital in Tallahassee, Florida, the capital of the state of Florida, a medium-sized city, about 140,000 people. So not a small city by any means, but still not a major city, not the size of Houston, for example, or Chicago or LA or New York. But having said that, this was the first American community hospital experience in robotic general surgery. ever in the literature. And I'm very proud to say that, not because it was the first, but because I was in a community environment. This was not an environment in a big academic university center. So it was a community environment. And I did this because I wanted to show and prove to myself that it is possible to establish a robotic program responsibly by mastering the learning curve, going all the way to the culprit, to the summit, to the most beautiful thing in the world, which is metabolic and bariatric surgery. So I started with basic cases, gallbladders, inguinals, and ventrals, etc. Moved on to other things like colorectal and anti-reflux surgery. And then case number 101, you may wonder, why not 100? Why 101? Case 101 was the first robotic metabolic bariatric procedure in the history of that city. And I say it with pride. This is just an example of what you can achieve. And back in the day, I was actually using the robotic Da Vinci S system, not even the SI. Forget about the XI or the X. I'm talking S, like the second generation robot. And that shows you that it is possible to do super complex surgery when you put your mind into it, when you actually want to do it because you train and your team trains with you. That was followed by another publication 2 years later, which is the first 200 robotic general surgery cases in a community hospital. So this was just the second part. Now we included some metabolic bariatric procedures, of course, bariatric primary and revisional procedures. And the story goes on. Then I had to move. I moved to another hospital, another environment, and I was in Virginia. I was in beautiful Winchester, Virginia. I did fellowship training after that, and then I did an interesting retrospective study on laparoscopic classic BPDDS or duodenal switch compared to Roux-en-Y gastric bypass in a high-volume community hospital, and the results were great. But then I thought to myself, why not do these procedures robotically? Let me establish a robotic metabolic bariatric program in this environment in which I was in a 500-plus bed hospital in a beautiful, gorgeous area called the Shenandoah Valley in Virginia, in a magical, beautiful area, but it was a rural area. So even though the hospital was massive, the city was medium-sized, small city, but it was a rural area by all standard definitions from the census, and it incorporated patients from a very large area, a very large territory, a lot of it farmland. And so I thought, why not establish a robotic metabolic bariatric program there? And it was possible. So this is another example of what you can do. Then we did it. We compared robotic Roux-en-Y gastric bypass, and we found out and published in Journal of Robotic Surgery that it was cost effective and it was feasible. And we actually saved money. And let's pay attention to this. We saved money by moving from a hybrid approach, because we started thinking that we were going to save money by using the robot and then doing laparoscopic stapling. We actually saved money when we moved on to robotic stapling. And then we saved more money when we moved on to robotic hands-on anastomosis. And yes, you may think that's going to take longer, but actually, no, it doesn't take longer. It takes the same amount of time. If anything, once you get good at it, it takes even less time to do it rather than doing a linear staple technique. And I hope to show you this. Another interesting point of view is you have this amazing machine that's so expensive. Once you have the tool, why not use it to your advantage? Why would you want to do linear stapling when you can use these extraordinary instruments that articulate better than the human hand and are an extension of your own hands? Why not use them to do hands-on anastomosis? And yes, you can do hands-on anastomosis laparoscopically. I can do it too, but it's much better, much more efficient to do it with the robotic platform, and I'll show you that. And so we demonstrated cost saving as well with this type of technique, and then we also studied, we went beyond that, and we wanted to see, okay, we have patients who have emergencies. We were a very high volume center, emergency bariatric surgery versus revisional bariatric surgery. Which patients do better? Which patients do worse? We published this paper on predictors of morbidity in revisional bariatric surgery and bariatric emergencies at this MBSA QIP accredited community hospital in Winchester, Virginia. And the results were great. It showed that when you use the robotic platform, you actually had better outcomes, clinical outcomes, not only financial, but clinical outcomes, fewer complications, fewer readmissions, fewer incidences of leaks and bleeding events. And I know what you're thinking. Well, Dr. Oviedo, Rodolfo, I thought that MBSIQIP publications showed that robotic sleeve gastrectomy has higher incidence of deep organ space infections like abscesses, etc. Remember, MBSIQIP is an amazing database, but it's a retrospective database. It's only 30-day outcome reporting. It's hundreds of thousands of patients in North America. The problem is it's a mixture, and you're mixing surgeons who were beginning to master the learning curve, other surgeons who were doing hybrid laparoscopic stapling with robotics or robotic assisted, not totally robotic. So you're mixing everybody. So careful with those data. Let's wait for more publications to come out. Let's wait for the high level, level 1 systematic reviews and meta-analyses, and then let's see what the literature shows. And then to go on, we did another type of sub-study on laparoscopic and robotic GJ revision for complications. This is a subset analysis from the previous study. We continue to show that robotic, metabolic, and bariatric surgery makes sense. So where are we going with all of this? What's my point? Well, in a study like this, taking into account the global burden of disease study of 2021, obesity is not just an epidemic. Dear friends, obesity is a pandemic. I know I'm preaching to the choir here. I know I am among experts. It is a pandemic. We already know that. So where do we go from here? Can we do something to democratize surgical education? Can we do something to become enabled, to become empowered to perform robotic surgery? If you have the interest, it should be possible. There has to be a way so that what we do is not driven by industry. It's not like it used to be where industry would dictate how you are trained. Can we do something different? And if you are not in a program, if you're not a resident or fellow, you're already graduated, you don't have the luxury of being in a program with a curriculum for robotic surgery, is there a third option that is independent from industry where you can train and become a robotic surgeon? Does it make sense to do that? And I want to show you that it does. We did a very interesting literature review based on behalf of the Clinical Issues Committee of ASMBS. And yes, we're in the GLP-1 era. I know it's volumes are down. We already know that. But at the end of the day, we will always continue to do metabolic and bariatric surgery. There's always going to be a need for revisional surgery, and robotic technology shines in revisional surgery. But I also recommend doing it for primary surgery, because this is how you get better, and your team gets much better and masters the learning curve. We know that anti-obesity medications are very useful, and they're a part of a continuum or spectrum of modalities, multimodal therapy, that we need to master as metabolic and bariatric surgeons. In other words, we should not make the mistake that other specialists, surgical specialists, have made in the past when they have not embraced non-surgical therapies, and now other specialists dominate those markets, right? We should embrace anti-obesity medications, work with our medical colleagues and counterparts. We should embrace it because it belongs to us. This is our specialty. This is what we do. This is who we are. Just like endobariatrics. We could talk about endobariatrics in another talk if I get invited in the future. And so this is a very important topic, very dear to my heart. Just to go on and show you the video, I also participated as second author on a very important ASMBS statement on how metabolic and bariatric surgery is useful and helpful and safe in the Medicare and Medicaid populations. For those who don't know, Medicare and Medicaid are programs in the United States. Medicare reflects to the social healthcare system for patients older than 65. That's when you retire, usually in the US. And Medicaid is for patients of underserved populations, low socioeconomic status. They don't have a lot of resources. And metabolic and bariatric surgery is, of course, safe and feasible and viable in both scenarios. So not only that, metabolic and bariatric surgery is very safe in colorectal cancer prevention. And it's very safe to prevent colorectal cancer and to reduce the incidence of colorectal cancer. We have shown this. It was actually shown and displayed at IBC Oxford at the Congress recently in September of this year. So we're very excited about the data on behalf of TROGGS. Now, when I was in Virginia, before I came to Texas, I even developed a randomized controlled trial. And it would be wonderful to collaborate with many of you on developing this as a multi-center trial. Developed this trial by which I was constructing a hands-on versus linear staple gastrojejunostomy, anastomosis. And we were able to enroll a lot of patients, but unfortunately I had to suspend the trial because I took another job opportunity in Texas, where I am now. But it is always possible. We can collaborate. We can do a randomized control trial. Half the patients can be randomized to do a linear staple GJ anastomosis. The other half can be done fully hands-on. And there are many studies in the literature that show that by doing it hands-on, you have more control, you have lower incidence of marginal ulcers, and you have less bleeding, fewer bleeding events. So there are many advantages to doing this. But example, this is one of the papers that I'm talking about. This is the experience from my dear friend, Dr. Vladimirov, who is the program director for the Intercontinental Training Program in Germany, and one of our the co-chairs of the Education Committee of TROGGS. I had the honor of being the senior author on this paper on robotic hands-on versus linear staple GJ, the German experience, published in Obesity Surgery from IFSO. We're very proud of that. And we were very transparent about the outcomes. I invite you to read it. All the outcomes on complications were disclosed, but it was a beautiful learning experience, and we can all learn from that. And also, my dear friend, Professor Christian Ramirez Serrano Torres from Mexico City, Mexico, he also performed and conducted his 3-arm Roux-en-Y gastric bypass technique with the robotic platform, published in Journal of Robotic Surgery. I invite you to read the manuscript. Of course, this is not advice on every patient. Patient selection is very important here, but you can even do beautiful things like doing a 3-arm robotic Roux-en-Y gastric bypass. It's feasible in select patients. Now, my technique, before I go into the technique, I'd like to show you what is the triple use of ICG. Well, we have robotic hands-on anastomosis. I'm going to show you a SADS, right? Single anastomosis duodenal ileostomy with sleeve. I'm going to show you how we use ICG or fluorescence for pretty much everything I do. I do it for colorectal, I do it for abdominal wall, I do it for foregut, anti-reflux, bariatrics, oncologic, HPV, everything. But in this particular case, we use it, number one, to identify biliary anatomy for those surgeons who are trying to master the learning curve, just beginning to master the learning curve, and maybe they're afraid of the duodenal dissection. Well, this is a beautiful way to do it. You give ICG 90 minutes to 2 hours before the procedure, just like what you do for a cholecystectomy. And then by the time you're in the OR, you can identify where the bile flows between the limit between D1 and D2, right? When the bile goes from the common bile duct into the second portion of the duodenum, you can literally see where that ICG goes. And that allows you to feel better about the dissection. Where do you end? Where do you staple? Even though we know that the landmark is the GDA, gastroduodenal artery. The second one is perfusion and ischemia assessment. You can inject it live. Anesthesia can give it IV in the OR so that now you can assess for perfusion of your anastomosis. And the third use is really interesting. We began using that a year ago, is the intraluminal use of ICG. You dilute ICG in 100 cc's of normal saline, you inject it via OG tube or bougie or whatever you want to do, and then you check in the OR, and it's extremely sensitive, even more sensitive than metal and glue. So that allows you to detect micro leaks, micro punctures from the needle, and you can fix them easily. And of course, in the United States, we still use endoscopy. We train a lot of our trainees on endoscopy. It's very important, but I complement it with the fluorescence. So let me show you the technique. I don't need to explain how useful the robotic platform may be for SADS, and SADS is an extremely important procedure recognized by ASMBS, endorsed by IFSO, and this is one of the NBS AQIP studies that we published on behalf of the Robotic Global Surgical Society. And of course, we compared the single anastomosis duodenal ileostomy with sleeve alone. We did an extensive systematic review, comprehensive meta-analysis on behalf of TROGGS. I invite you to read those papers, but let me show you the technique. Special thanks in this case to my mentee, Dr. Mikhail Kutentakis, who is proudly Greek, and Mikhail is a wonderful mentee of mine, a dear friend. He's one of the administrators for the consortium that I lead called On Behalf of TROGGS. I'm very grateful to him for editing this video, and let's do it. So the position, as you can see, is reverse Trendelenburg. We begin with a more flat position or neutral when we identify the ileocecal valve, but later on we switch to reverse Trendelenburg. This is the port placement, very easy diagram. This is the 12-millimeter trocar right here, and the right mid-abdomen. The other ones are 8. And that's it. Notice there is no trocar for liver retraction. I'm going to show you why, and I think you know why. So let me start with the video, and we're almost done. I just want to show you this 5-minute video. So let's begin. We begin by identifying the ileocecal valve. I don't need to double duck for this. We just go in and identify. We count retrograde to 300 centimeters on the ilium, and now we're going to fix that ilial loop to the right upper quadrant greater omentum. We're going to put stitches. Usually one single tail is proximal, two tails is distal. That way we don't twist it, right? We don't cause any twist. And now we're going to leave it there. At this point, we would change the position to reverse Trendelenburg. We're going to do the liver retraction stitch. This is pretty easy. Anybody can do this. Really, it's just barb suture that you're using to elevate between the left lobe of the liver, between the left upper quadrant to the diaphragm, to the right upper quadrant. Be careful, obviously, with the vasculature, the pericardium. Of course, be very careful there, but usually with proper traction, countertraction is useful. Typically, I use only one suture for this matter, but sometimes I end up using two sutures and very rarely three to elevate very large liver lobes, right, with hepatomegaly. Now, when we do that, now we get ready to enter the lesser sac by dividing the gastrocolic ligament. Notice how all the arms of the robot are being used. Is a dynamic use of the arms of the robot. You're constantly swapping to use that fourth arm actively and retract very nicely. We're doing the retrogastric dissection. We're going to the retroduodenal region, and now we're going to use the first use of ICG. We're going to use it right there. You can see where the bile will flow into the second portion of the duodenum, right there. You can see that green area, the ICG is going there. So that's the second portion of the duodenum. And you need to stop at the GDA anyway, right? So you're going to stop at the gastroduodenal. Notice the beautiful way the arms are moving. Articulation is phenomenal. You have a lot of tools at your disposal. Can you do this laparoscopically? Absolutely. I've done it. You've done it. No problem. We can do it. But ergonomic advantages, no doubt. You have more advantages here. Can you do 2 or 3 ADSs in a single day laparoscopically? Sure, you can, but I think you might be tired at the end. I certainly was. But with the robot, you can do 5 if you want. I mean, you can sit down, you can be relaxed, you can protect your back, your neck. There are some disadvantages too, the way you sit. If it's a closed console, open console, we can discuss that later. But there are many advantages that I don't need to mention, of course. Now here we're showing the calibration with a bougie. There is a 40 French bougie in there. We're staying away from the bougie, and now we're using blue loads first and white loads afterwards. We're downsizing the staple height because of the less thickness of the proximal stomach. Here we're dividing first versus second portion of duodenum, leaving at least 3 centimeters of duodenal bulb. And now we're assessing with the second use of ICG. This is ICG injected live by anesthesia. Even though it looks a little blue and funny, it's just vascular venous congestion. It's not ischemia, obviously, because you can see the green fluorescence, right? And with the ICG at the duodenal bulb. So that's why I can go to sleep at night. I know my patient's going to be fine. It's not going to be ischemic, right? Now we're doing a 1-layer hands-on anastomosis. Now, I learned this from my European colleagues. I used to have a mentor, rest in peace, in residency, who would say that Americans are trained to do everything in 2 layers. The Europeans do it in 1 layer. I don't know if that's true or not necessarily, but I know that a lot of my friends do 1 layer, so why not? I'm doing 1 layer, duodenal ileostomy, that's it, with barb suture, and it's absolutely fine. Patients do well. So whether you do it with 1 or 2 layers, it doesn't really matter. The literature doesn't show any preference. You can do it either way. See how we're entering in a very controlled fashion. We're going to use the ICG to assess the mucosa and for perfusion. There you go. Now, the bougie I'm using right there is compatible with ICG. So it's kind of nice to be able to advance that bougie and under fluorescence. But now we're using the anterior layer, closing the anterior layer. Of course, use that fourth arm to retract very nicely anteriorly to prevent back walling of the anastomosis. You see it's all controlled. It's very efficient, very smooth. And many times you can actually switch it with your left. It doesn't really matter. Now we're doing the leak test. ICG, you can see a micro leak right there. You see that micro leak is extremely obvious. I mean, so obvious that now I can put a figure of 8 stitch with micro. End of the problem. That's it. I can go to sleep at night. I know my patient's going to be fine. And then at the end, once we fix it, we repeat the test, of course, with the dilute ICG and saline. But then at the end, we're still clamping the afferent and efferent limbs, and we're going to do endoscopy. And with the endoscopy, because we're in the US, we always do endoscopy, right? We train our trainees to do it. We usually have no problem with having an endoscope tower in the OR. Well, we do the endoscopy, we correlate, and it's all good. The patient goes home the next day, no drain, and patients do really, really well with this technique. So just to conclude, I know that we're running out of time and out of respect to everyone else. This is the concept, one of the concepts of TROGGS, the Laboratory for Augmented Surgical Training, LAST. This is present in every intercontinental training program from TROGGS. We have multiple industry partners that support our educational endeavors. We're a nonprofit society. Nobody gets paid for this, by the way. We do everything out of passion and love and generosity for our mentees. But this is nonprofit. We have companies that donate equipment to us so that we can do simulation in the lab like this. These simulator models, we use them in ITP centers throughout the world, including 3 centers in Europe, by the way. And all together, it's going to be 11 centers throughout the world at the Intercontinental Training Program, one of our contributions from TROGGS, just like this. I created this metric scale, in collaboration with my other colleagues. It was a creation of mine when I was at the Texas Medical Center, the largest medical center in the world. I say it with humility. I wanted to understand how to better train my mentees, and I knew that there was something else to do. We had to do something better. And I created this metric so that with 10 skills, we can evaluate the proficiency and performance from an operator, and we can train anybody to do robotic surgery, independent of the specialty and procedure. And then we came up just recently, a few months ago, with the CARS 2.0 curriculum, which was a global validation study survey validated by by 320 reviewers who analyzed the video, and we had outstanding results. So I invite you all to read the manuscript. It's open access. I invite you all to exchange ideas with me on how to implement it, to train your trainees and anybody that comes into contact with you as surgical educators in Greece and beyond. And this is an example of what we've done in Germany. We have courses, for example, at the Frankfurter meeting where we institute and implement CARS. This is an example. We're launching CARS 3.0, which is going to be the massive worldwide curriculum.
Professor, unfortunately, your connection is
colleagues and
not
friends in
very
Greece,
good.
we'd love to work with you so that we can all collaborate and be authors on the paper. It's going to lead to a series of papers in surgical education. We're very excited about this collaboration. Of the Intercontinental Training Program, and we have multiple centers throughout the world, in the Americas, in Europe, in Asia. No Africa yet, but hopefully soon. And we have 11 centers now to be recognized. And just to recap, I hope that I convinced you. I tried my best to convince you about the objectives. I hope they were met. And this is my simple algorithm. If you have a patient with objective criteria for metabolic bariatric surgery based on IPSO and ASMBS standards, and you have a robotic multi-port system or single port system or modular, even a small robot, doesn't have to be the fancy one, the most expensive one. If you have proper training, we can help you at TROGGS. We can help you train, and you can implement metabolic bariatric robotic surgery. Ideally, with barb suture, I recommend you do hands-on anastomosis as much as possible, and with fluorescence if you have that capability. I encourage you to do that. And just to finish, I would say robotic bariatric surgery, why not? Why not? Think about it. Embrace it. Think about the future. Remember, we won't be replaced by people, by AI, but we'll be replaced by others who embrace and understand AI and robotics. Let's do it. In conclusion, and I invite everyone to attend beautiful Luxembourg in July 8 through 10, 2026. We're going to have the TROGGS Congress. I invite everyone to attend. Very easy, accessible cost of registration. The call for abstracts will be open in a few days. We are looking forward to seeing you there. Professor Pantelli, certainly I want to see you there, my friend. And in conclusion, what I advocate for, and I want to convey to you, is to embrace the totally robotic approach. If you have the capability to train, please do it. Please consider it. Do it with us. We'll be happy to help you. Robotic metabolic bariatric surgery with hands-on anastomosis and fluorescence is the way. This is the way it's being done. It's the present. And with platforms such as the CARS curriculum and other AR/VR platforms, with the versatile use of ICG, nothing is impossible. You can do responsible, cost-effective, efficient metabolic bariatric surgery with robotics. And yes, even with smaller platforms, to democratize robotic surgery. It doesn't have to be with the fancy ones, with the complex ones. Robotic surgery is not the future. It is the present. Think about it. We've been living in the robotic revolution for more than 2 decades. This is nothing new. It's not the future. We're living in the present. This is the present. Let's go. Let's do it. Let's train. Let's collaborate. Let's not fall behind. It's never too late to start. And at the same time, remember, we're not saying to do robotics for everything. Surgical judgment is at the core of what we do. Whether you do lab or open, robotics, endoscopy, everything has to do with patient care. We're not advocating for using one technology only or one modality, not at all. That's not the purpose of TROGGS. So having said this, inviting you all to attend the Congress and opening myself for questions, I invite you all to also visit me in beautiful Nacogdoches, Texas, USA, the oldest town in Texas, even though in terms of Greek culture, that's nothing, right? That's the blink of an eye in terms of antiquity. But I invite you all to come here. It's a beautiful, beautiful, gorgeous area of Texas, piney woods. I will treat you as you deserve. And if you are at the level of attending or consultant level surgeon, will treat you as part of the visiting professorship program for TROGGS. If you are a resident watching or fellow, you can come in for a fellowship. If you are a medical student, you can come in for an observership. Apply through the TROGGS website. I invite you all to become members for free. And with this, I say thank you very much. You have my gratitude, and I look forward to seeing you again. Thank you.
Thank you very much, Professor Oviedo. The pleasure was ours to have you today with us. And I would like to ask the audience for any questions. Would you like Thanasis to ask something yourself, or?
Saying just thank you is an understatement, and to express my gratitude and the gratitude of all of us in BariClub for this eye-opening lecture. I found it very inspiring, particularly in the part you said that you started everything from community hospitals, non-popular hospitals, which is more or less the case in Greece in most public and private hospitals. I think that this would be a kickstart of the popularization of robotic surgery in Greece. It would be a very smart platform to start. And of course, the second message and the most important is that TROGGS and your program is open to everyone at any stage of surgical practice. And this is something that I should keep, both in the personal aspect and the political. Thank you for being with us tonight.
Thank you.
Thank you very much. And I absolutely, I echo your words, and I am grateful to you and to BariClub, and I invite everyone to join, and absolutely, we can collaborate together. This could be the beginning of something great. And one thing I have to say, I know that some of our colleagues from different parts of the world may say, that sounds great, Dr. Oviedo, but we don't have a robot, right? Or we just don't have a way to get it right now. We don't even see how it's going to be possible. It's never late. It's never too late to start learning about it anyway, right? And even if your hospital doesn't have the capability to buy a robot now, it's coming. It's becoming cheaper because of the competition. We need more competition. And it's never too late to start learning anyway. By the way, one thing I did not mention is that TROGGS is already offering an accreditation service for companies that want to have their courses accredited. We have a peer review system of judges. We can judge the quality of the programs, and if they are in accordance with our standards of quality, they can be accredited. And we are also in conversations with different labs throughout the world so that we can have discounts for our members. And this all membership is free, and of course we get discounts for training. And coming to ITP, even though in some programs throughout the world, out of the 11, in some of them like mine, it's not allowed to lay hands on the patient because internal regulations from the US. It's an observation type experience, but with simulation. So we do simulation. Every procedure is on the synthetic models that I showed you. And we can replicate any procedure on the synthetic model, and is highly academic. So thank you for the comments.
You have a valuable contribution to the robotic training, I understand. And I have a question, especially in Greece. It's like you said before, in my knowledge, I only see 2 or 3 public hospitals with robotic machine right now. So my question is, could you please tell me what would be the ideal training pathway for me, for a bariatric surgeon, to train in the robotic surgery and have a proficiency? And what happens then when I come back to my hospital and we don't have the machine yet? the robotic platform yet. Is this knowledge declining by time, or what happened?
Excellent questions, and we do have solutions for that. The beautiful thing about it is our collaboration with TROGGS, our ITP affiliated centers. There are multiple in Europe. You could potentially travel to France and Germany and Luxembourg, and hopefully in the future we'll have another one in Poland and Greece. And so we're extending so much that you could travel to any of those centers where you could continue to maintain your robotic skills. Because even if you don't operate on patients because of internal regulations, even though in Europe it might be a little bit easier for Europeans, you can still do the procedures on simulation models. And we have that beautiful simulator model that almost resembles human tissue, where you can practice the procedures yourself at our ITP affiliated centers. And to do that, to receive that education, is absolutely free for our members. I used to pay $3,000 for a 2-weekend type of course at a big university. Of course, $3,000. This is free education for our members. Of course, you would have to, anybody, not just you, but anybody would have to to finance their travel expenses. But having said that, we're also working on getting sponsorships so that our mentees can get sponsored as well. And we have a scholarship award generated twice a year by TROGGS. And we, all the funding, all the money that we get is not for us, but it's to mentor, to sponsor our mentees. So we have a scholarship award. We already launched the first one. That's another example how you can get reimbursed for your travels. Or you can come to the United States. I know it's a longer trip, but I'll be honored to have you and welcome you here and teach you what I know, as much as I know.
Thank you very much. And I have one more question. What about the new medication? And about the, I know that in the USA, the government gives funding to the hospitals, and it depends on the how many cases they have. What about the new medication, the obesity medication? Has this medication changed the funding you get from the government? Is this having any effect to your practice?
So the first part of the question, the medications, they're definitely affecting all of us. So because the volumes are down, no doubt about it, but they will come back. And the reason is several reasons. There will always be an indication for robotic revisional metabolic bariatric surgery. So that's not going to stop. The first thing, though, is that literature shows, big studies have shown already that less than 20% of patients who start GLP-1 therapy, and I'm assuming we're talking about the new kid on the block, the GLP-1s, right? 20% will be on GLP-1s at 2 years. And it's multiple factors, finances, side effects, adverse effects. So 80% of people will quit for one reason or another. And so it's just temporary, right? They're very good. They're very good at what they do. But there are some issues, and it's not long-term, right? Well, metabolic and bariatric surgery offers GLP-1 for life, right? And we're just generating our own GLP-1, autologous GLP-1. And so that's one. Now, the second one is, no, actually, hospitals don't get funding from the government to promote GLP-1s or medications. No, so what's happening, though, is many insurance companies are preferring the GLP-1s, and they're reimbursing less and less and less for surgeons. Or they're putting strict criteria so that you can perform surgery only if you are a center of excellence. They call it center of excellence, and they have their own criteria. For example, I was brought to this community, to this beautiful area of Texas, to establish an MBSA QIP center. And mission accomplished, thank God. We did it. 2 years, and we have it. 3 weeks ago, we had the honor of getting that letter from the American College of Surgeons that we are now an MBSA QIP center. In fact, I didn't even add the logo to my presentation. Next time I should. But having said that, that doesn't end there, because guess what? Now we have to apply for the next step, which is COE, or Center of Excellence, with each insurance company. So it gets really complicated, but it's just the beginning, not the end. We're not going to give up. But just to answer your question, yes, volumes are down, but they're coming back, slowly coming back, for different reasons. One reason is what I told you, 20% of patients will be on them at 2 years. The other 80% will quit. The other reason is, for one reason or another, the other reason is there's always a need for metabolic revisional surgery. That's not going away. We're always going to do that. Now, sure, You also need to embrace other procedures such as anti-reflux and abdominal wall. So I encourage all of you, my dear friends and colleagues, to embrace it, because guess what? Our specialty is so beautiful that it's like a triangle. If you think about it, we're within general surgery, right? We're a super specialty of general surgery. When patients tell me, are you, some patients don't know, they may not know the difference, and they may say, oh, you're a general surgeon. I thought you were a specialist. You're just a general surgeon. And I say, no, wait. It's not like that general. Think about general surgery as in the general of the army. So like you have to command everything else, right? You have to have knowledge from the esophagus to the anus, from the abdominal wall at the front to the retroperitoneum. You have to master everything, right? Humbly saying it, we have to know so much, right? But we are a super specialty within the specialty of general surgery. Now, where I'm going with this is, we have a triangle of specialties in which we do metabolic and bariatrics, but we also do anti-reflux surgery. And that's not going anywhere, right? We also establish a very high volume anti-reflux center where we are. And at the same time, we will always have patients with hernias that nobody else wants to take. Few surgeons may want to take care of because they have obesity. So we will be the ones doing the complex ones, which generates more metabolic and bariatrics, which generates more anti-reflux, which you see how it is? It's a cycle. So many of my friends and colleagues in the United States have had to embrace other specialties too, or other super specialties like anti-reflux and abdominal wall reconstruction, so that we can continue to work and offer the best of our talents to our patients.
Thank you very much. Your talk was impactful for me. Thanasis, would you like to, is there any other questions? I'm sorry. Are there any other questions from the audience? Okay. If no, Thanasis, would you like to close this beautiful evening?
Inspiring. All of Professor Oviedo's words have been inspiring. I think for everybody attending this meeting at all stages of surgical practice. And I'm so thankful and so glad that he accepted our invitation and we were able to gather all these people together tonight to have this work spread throughout. Thank you so much. Thank you everyone for attending. Thank you, Professor Oviedo, once more for tonight's speech, for all of our collaborations, and for being so humble, for being so open, regardless of your duties, regardless of your position. You are truly a man of your word. I have confessed firsthand that you are open to new collaborations and to new ideas, and I can appreciate it.
It's really my privilege and honor, dear Professor Pantelis, my friend, and I want to thank everybody, because I know it's late in Greece. I know it's late, and it means a lot to me. You might as well be with your families, having dinner, enjoying. So thank you for staying late for me. It means a lot, and for your flexibility. And always count on me. I'd be happy and honored to come back and give a lecture again and share ideas with you and learn from you, not just to teach you, but to learn. Thank you.
Thank you very much. Thank you, everyone, for being here tonight. See you at the next BariClub.
Next year, actually.
Next year, yes. Have a good night.
Thank you, everybody.
Thank
you very much.
Okay.
Goodbye.
Good night and congratulations. Good night.
Thank you. Thank you, Doctor.